Welcome in everyone to the recording of our week 3 of our exam 3 content. This is going to be talking about the high risk newborn and the things that we need to be kind of adjusting for from the nurse's perspective. If you'd please go ahead and do your QR code to sign in. Alrighty, here we go. With the initial stabilization of the neonate, we can pretty much do ABCs, but at the end of it, it's going to be thermoregulation as well. We're going to make sure to suction if needed. We're going to put them on their mom's chest to initiate that skin-to-skin contact and make sure we are drying the newborn so we're not having any thermoregulation problems. We're going to put them on the radiant warmer to kind of just make sure things are okay. After that, we're going to make sure that the cord is cut and it's clamped accurately. Followed by the Apgar score at 1 and 5 minutes. And then we're going to make sure we're doing the erythromycin at kind of at the same time that you're weighing the baby to make sure that we're preventing eye prophylaxis. And then aquamaphytin, which is that vitamin K, promoting clotting factors to give this in the vastus lateralis. Alrighty. In regards to methods of oxygen delivery, we have a few here. We have just the bag and mask, the oxy hood, high flow nasal cannula, and a CPAP. The CPAP uses positive pressure to keep our airway open for the baby. And if needed, there also is intubation, ventilating them to keep the lungs open. It's kind of with that. Alrighty. In regards to circulation and resuscitation, in most cases, the newborn will not need chest compressions, although they will respond to appropriate oxygenation and ventilation. However, in this case, these don't work. Resuscitation will be started per protocol. We have to assess their heart rate by looking at the stomach or umbilical vein. And then intravascular access. The umbilical vein is used for the meds and the IV fluids. The umbilical artery is used for obtaining blood, sampling, and monitoring blood pressure. Okay, now going into thermoregulation. We've already kind of talked about this, but really just, our biggest point is that a cold baby would be a dead baby, or at least very sick. So we have some methods to kind of prevent that. We have radiant warmers. We're going to put a cap on their head, blankets and plastics bags to keep heat in, bear huggers, double up the blankets for swaddling, and of course, skin-to-skin contact. Next is going to be that high-risk newborn. We do have, this means that one who is susceptible to illness, morbidity, or even death, mortality because of the dysmaturity. So that'd be like a placental problem, immaturity, maybe they're preemie, physical disorder, or a complication during or after the birth. All right, high risk conditions. We have a SGA baby, a small for gestational age baby. The definition of this is that they're small, although their gestational age is, I wouldn't really say normal. An infant born is in that less than 10% percentile of that birth weight. Of course, in regards to gestational age, they can be preterm, term, or post-term. The effect on the fetus this can have is that they have appropriate size heads and are appropriate length, but their overall body weights and organs are diminished. Risk factors of this could be circulation, so smoking, hypertension, maybe a malnutrition, substance abuse from the mother, multiple gestation, maternal diabetes mellitus, cardiac or renal disease. And some of the complications of this would be like fetal hypoxia, low thermal with hypothermia, low blood glucose levels, hypoglycemia, polycythemia, and respiratory distress syndrome. That's what that RDS is. Okay, next is preterm infants. Any infant born before the 37th week. Okay, the effect on the fetus this can have is that the different systems aren't really fully developed or ready for that extrauterine life, so that life outside of their mother. Risk factors of this can be, of course, if the mother has a history of preterm labor, if they have any infections occurring, maybe it's something as simple as a UTI. Smoking, hypertension, malnutrition, substance abuse, moms, multiple gestation, are they twins, maternal diabetes mellitus, or cardiac renal disease. For the common complications, just stay tuned. We're going to kind of discuss a little more. IUGR, intrauterine growth restriction. This is whenever they are at an advanced maternal age, they have very limited fetal growth. Risk factors of this can be caused by maternal, placental, or fetal factors. So if you were to look at the SGA, kind of a similar stuff. The effect on the fetus, the infants have appropriate sized heads and appropriate sized length, but their overall body weights are diminished. Common complications of this would be fetal distress, hypothermia, hypoxia, aspiration syndrome, and the hypoglycemia, which is the most common metabolic complication. Polycythemia, bradycardia due to decreased cardiac glycogen stores. Maybe a decreased glycogen stores also lead to things like hypothermia, and of course, just hypoglycemia. These babies here are at risk for a C-section, increased risk of hypoxia, increased risk for meconium aspiration. This could cause an overdistended alveoli, maybe like a pneumothorax, or a bacterial pneumonia. Of course, hypoglycemia again and again. One other thing to mention would be that these babies are decreased blood flow due to the increased number of red blood cells. That's pretty much that right there. Large for gestational age babies, so macrosomia. The definition of this is that these babies are born above the 90th percentile of intrauterine growth. The effect on the fetuses can have is that they can make a larger, complicated labor, as well as a harder transition to extrauterine life. Risk factors of this could be common with things with like diabetes, whether it be gestational diabetes or just the mom has diabetes as well. Some of the common complications of this can be birth trauma from vaginal birth, whether they have things like a fracture, a depressed skull fracture, or maybe a cephalohematoma. They could be at risk for hypoglycemia due to early depleted glycogen stores. It's kind of like they're just cut off from the mom's glucose supply. They were soaking in all that sugar, now they're not anymore. With the fetal distress, they could be caused by prolonged and difficult second stage of labor. Things that may occur, shoulder dystocia, passage of maybe a meconium, aspiration in utero, with, of course, the risk of aspiration. Some of these LGA babies, they're at risk for hyperbilirubin levels related to the increased level of bilirubin released from that damaged red blood cells secondary to the dramatic delivery. They could be, we've already said this, but they could have a birth injury, whether it be a fractured clavicle, maybe a shoulder dystocia as well. So whenever you're kind of assessing these babies, you want to make sure that we're measuring their birth weight. The assessment depends on whether the infant is preterm, postpartum, or at term. You want to kind of check for signs of birth trauma, and you want to make sure that they are not hypoglycemic, especially if they have a mother with diabetes. Some of the interventions we want to do with these babies are to continued assessment, looking for that dystocia and fractured clavicle, making sure we're monitoring two levels. This is going to be the blood glucose and the bilirubin levels. We want to also monitor for polycythemia. We want to make sure that we are educating and supporting the family whenever their child is bruised slash or injured. Alrighty, and the thing we're kind of looking for end goal with evaluation is we want to make sure that these infants are transitioning from a extrauterine life, to extrauterine life without that birth trauma or injury. Kind of breaking this down by system. These are the, what's it called? The alterations of our preterm infant. Within the respiratory system, their lungs aren't fully developed. There could be maybe a lack of surfactant. In regards to temperature regulation, they are less availability of glycogen in the liver. They have less subcutaneous fat. They have a high ratio of the body surface to body weight. And of course, their skin is very thin. So that heat that we have internalized, they're just releasing it. They could have a immature GI system with problems related to ingestion, digestion, and absorption. They could have a risk of aspiration. And maybe they're having an increased risk of feeding intolerance. Also, they could have an alteration in renal system, whether they have a lower GFR because of the decreased blood flow going to the kidneys. What would we need to monitor for? This would be things like kidney dysfunction. So babies have trouble regulating fluids and excreting their waste. We need to monitor their bilirubin levels that is excreted through the urine. We also need to make sure we're doing a very strict INO for these babies, counting the number of diapers, weighing these diapers. That's how you would kind of do that for these babies. Whether it's hepatic and hematologic, we could have an immature liver. We could have hypoglycemia due to the glycogen stores that are being used for energy. Maybe they're anemic with the low iron stores. Maybe even they have jaundice because of their increased bilirubin in the liver. They could have septic due to their decreased immune system, kind of from them being very premature, or maybe that they're having a hemorrhage due to their just being premature and having some neurological problems from that. Alrighty, general complications for the high risk newborn. Alrighty, there are actually going to be within respiratory distress. We have three types of right up here. We have respiratory distress syndrome, aka hyaline membrane disease. Respiratory distress syndrome is typically among our preterm infants. Okay, the next one is going to be or actually C right here, meconium aspiration syndrome. That is usually among our term and post-term infants. It's with that transient tachypnea of the newborn. This is actually due to the delayed absorption of fluid in the lungs from delivery. Typically affects our term and post-term infants. All right, a little bit more about the transient tachypnea of the newborn. This primarily occurs in term infants, especially if delivered by a C-section, because they have not experienced that mechanical squeeze that occurs during the vaginal delivery. So they very well could have some fluid up in there. Okay, in regards to the meconium aspiration syndrome, this is whenever we're having an aspiration of meconium into our bronchial tree during the first few breaths after the delivery in a term neonate. This could definitely lead to persistent pulmonary hypertension of the newborn, but that's not something that's really that important for this. The assessment of these babies, they're going to have signs of fetal distress during the delivery process. Their Apgar score would likely be less than 6 at 1 and 5 minutes. They're going to have immediate signs of respiratory distress and delivery, whether they be cyanotic, they're going to be having retractions, or they're going to be tachypneic as well. They're going to maybe having a barrel-shaped chest or a diminished breath sound. They could have a yellow stain of their skin, a yellow stain of their nails, and their umbilical cord. For these babies with the MAS, meconium aspiration syndrome, we're going to make sure that we are suctioning their oropharynx, then the nasopharynx after their head is born and the shoulders and chest are still in the birth canal. If the meconium is thick and amniotic fluid, then we're going to want to place them underneath the radiant warmer. We're going to make sure we're visualizing their glottis and suctioning any meconium from the trachea before, of course, doing our respirations. We're going to make sure that we have anticipated a potential need for mechanical ventilation, which would be for, or maybe even an ECMO. An ECMO is something that you're going to see within peds. That's not something really for OB, but an ECMO is called the intracorporeal membrane oxygenation. They're really cool. They have a lot of these thick blood things that's going on, and they're actually allowing the lungs to heal by doing the heart-lung bypass. Okay. Whenever it's our babies with the transient tachypnea of the newborn, these babies can be seen with expiratory grunting, nasal flaring, and mild cyanosis. They may be tachypneic by 6 hours of age, and their RR, respiratory rate, maybe get as high as 100 to 140 breaths per minute. These babies, we want to make sure that we are giving oxygen as needed to maintain their oxygen levels and their oxygen saturations within normal limits. These things here for the transient for B usually resolve within 72 hours. Alrighty. Alrighty, in regards to cold stress, the patho is the infant's unable to maintain their body temperature. These neonates are really they're not able to, shiver, things like that. Okay. These babies are at risk of hypothermia because of a large surface area to mass ratio. A large amount of these heat is lost from their head. All newborns are at risk for hypothermia, especially preterm and SGA babies. Okay. In regards to the treatment here, we want to make sure that we're slowly rewarming. We're going to be checking their glucose levels and giving oxygen if needed. We want to make sure that we are maintaining a neutral thermal environment by reducing or taking away the heat lost that could be from drafts or contact with cold objects. We want to make sure we're postponing their initial bath until the temperature has stabilized. And we want to make sure that we're drying them immediately after delivery and when bathing. We're going to make sure that we're assessing their body temperature, keeping the axillary body temperature from 97.6 all the way to 99.2. If their axillary temperature is less than 97.6, well, we kind of do this already, but we want to make sure that we have a hat on the infant's head. We're going to wrap them in warm blankets. We want to assess oxygenation levels and also assess for hypoglycemia. We want to rewarm them slowly to prevent hypotension and apnea effects. And we want to be aware that chronic hypothermia could be an early sign of sepsis. Please be aware of that. Alrighty, this is our next slide. In regard to hypoglycemia, really the etiology of this is we have a blood glucose level that's less than 40 in a term newborn. These levels are usually assessed through a heel stick. These newborns are at risk, especially if their mothers are diabetic, if they're small if the baby themselves are small for gestational age, if they're premature, if they're experiencing cold stress, hypothermia, or delayed feeding is occurring. They have a poor prognosis if their hypoglycemia is not treated, and their glucose level usually stabilizes within 48 to 72 hours if treated. So in regards to the assessment of these babies, they're going to be extremely lethargic. They're going to have some jitters going on. Um, they may have some tremors going on as well. They're going to have a decreased muscle tone. They're going to be anorexic, so they're going to might be not able to be feeding, and they're going to be apneic as well. If we're kind of talking about nursing diagnosis for these babies, it's really just going to be imbalanced nutrition. Okay, so we want to make sure that we are checking their blood glucose levels by 1 hour of age. And if they're going to be, if their mothers are diabetic, we're going to assess them even at 30 minutes of age. We're going to make sure that if there's any signs and symptoms that is treated immediately. A lot of times they can even treat hypoglycemia by breastfeeding immediately or feeding to maybe with an intravascular IV. Okay. If we are attempting to treat this hypoglycemia, or we want to make sure that we're assessing their blood glucose levels before the next feeding. Okay. Let's look at this slide. All right, hyperbilirubinemia, aka jaundice. We have two forms of jaundice. We've talked about this last week. Within physiological jaundice, this is that jaundice that's occurring after 24 hours. Okay. A normal newborn has 2 times as much bilirubin as an adult, related to a higher concentration of red blood cells circulating throughout the body. Factors that are increasing the risk for a physiologic jaundice could be an infection, dehydration. Worst to worst, it could be sepsis. The other things that we have to mention is maybe they have had a cephalohematoma. Maybe they're having lots of bruising from their difficult delivery process. So that's kind of what we're talking about when we're discussing physiological jaundice. With pathological jaundice, this is the one that occurs within 24 hours. Big distinction right there. A common cause of this could be an RH incompatibility. If the mother is RH negative and the fetus is RH positive, well, the fetal RH positive red blood cells are going to enter the mom's bloodstream through breaks in their circulation late in pregnancy. And after the separation of the placenta at delivery, antibodies will be formed. And within the second baby, a subsequent pregnancy, another RH positive fetus, their antibodies will cross the placenta, enter the fetal bloodstream, and attack those red blood cells, causing hemolysis and fetal anemia. Things that are usually done with this is RhoGAM is usually given to prevent development of these antibodies, but it cannot reverse the reaction once it's occurred. That's why we've always talked about that sensitization, okay? All right. Maybe even an ABO incompatibility. If the mother has a blood type O and is carrying a fetus with a blood type AB or AB, these fetal red blood cells can enter the mom's bloodstream through breaks in the maternal fetal circulation late in the pregnancy, of course. And after separation of the placenta at delivery, mother will make antibodies, and within the subsequent pregnancy, those antibodies will cross the placenta once again and attack the red blood cells. Okay, so some things that we're usually doing on this, we've already kind of talked about the indirect Coombs test and the direct Coombs test. So kind of assessment of this with the indirect Coombs test, that's assessing the maternal antibodies, whether they're sensitized. With the direct Coombs test, we're detecting if there's a presence of the RH antibodies within the fetal blood, okay, directly on baby. Okay. You can usually assess for jaundice by gently pressing on the sternum of the forehead, or in a dark-skinned infant, looking at their sclera, the palms of the hands, and the soles in their feet. Alrighty. Within interventions of this, we can do what's called phototherapy. phototherapy is an exposure of infant to bright light. It's kind of a cool little blue light that you'll see in the nursery. We want to make sure that we want to make sure we're covering the infant's eyes when they're underneath the phototherapy light. We're going to remove the eye covers every 2 hours when under the light to assess for conjunctivitis, and not and when the light's off to promote bonding. We're going to change the infant's position every 2 hours and assess for skin breakdown. We want to also make sure we're looking for if they're having any loose green stools, as bilirubin is usually excreted through the intestines. We want to increase their fluid intake to prevent dehydration, and we want to make sure that we're assessing our temperatures of these babies every 2 hours and monitoring for hypo or hyperthermia. Kind of just as a general thing, we want to also make sure that we're covering their genitalia. We don't want the light really having an effect on there. A lot of times they're going to be wearing the really cool glasses, and we want to make sure, of course, that we're having a strict INO, as bilirubin is usually excreted through the urine as well. Alrighty, here we have our congenital heart defects. In regards to these, you're not really going to be tested on the different types of the CHDs, but I would definitely say that you could be tested on how to assess for these. So we could have a patent ductus arteriosus. The connection between the pulmonary artery and the artery diverts blood from the pulmonary vascular bed to the body. In the term, infant functional closure occurs by 12 to 15 hours after birth. This would be called persistent if it remains functionally open beyond 72 hours. And to kind of treat this, we're going to be giving them NSAIDs, okay? Something to really be important with this is we want to make sure that our mother is not taking NSAIDs during pregnancy. Those are prostaglandin inhibitors, which can affect the prostaglandins that maintain fetal circulation. The NSAIDs would close the ductus arteriosus. Although these NSAIDs can be given after birth to help close the ductus arteriosus, a ductus arteriosus on a baby that has been born is it would not be good if it stays patent, and we don't want it to be. Maybe it's a coarctation of the aorta. To kind of assess for this, you would have a systolic blood pressure that's higher in the upper extremities compared to the lower extremities. I'll see if I can kind of draw some cool stuff on here. With the coarctation of the aorta, your aorta, you know how it goes throughout the whole body. Well, the coarctation of the aorta, it's going to look like a little sausage link. So essentially the blood is not able to go out that much, okay? That's just kind of what's happening there. With the tetralogy of the fallow, you're having 4 defects: pulmonary stenosis, a VSD, so you're also having an overriding aorta, and a right ventricular hypertrophy. I guarantee that wouldn't be on your OB test, but that definitely will be on your PEDS test. Just understand that that has 4 defects, tetra. Alrighty. All right, next is going to be sepsis. The patho of this is that we just have blood that's gone into the bloodstream, an infection that's gone into the bloodstream. Assessment of this is that they're going to have poor blood sugar and temperature control. A lot of times it could even be hypothermic. Poor feeding and activity, vital signs, the bleeding problems, the inconsolability. So they have a high-pitched cry, but nothing's really relieving it. Diagnosis of this is going to be with the cultures, and of course, kind of just blood scans. And then treatment of this is going to be antibiotics. In regards to interventions for sepsis, we want to make sure that we're obtaining cultures, whether it be blood, urine, or maybe even a cerebral spinal fluid, before antibiotics are initiated. We're going to administer the antibiotics that are ordered, and we're going to observe for changes in vital signs and the physical assessment. For the assessment of sepsis, these temperatures are usually unstable, especially hypothermia. They're going to have feeding intolerance as evidenced by their decreased intake, the abdominal distension, vomiting, and poor sucking. They may even have some subtle behavior changes. The infant just doesn't look right, the mother says. They're lethargic and they're having some pallor occurring. They may be having some high bilirubin levels. A lot of times they can even be tachycardic initially, followed by the periods of being apneic and bradycardic. Yes. All right, that's pretty much it for that one. Oop, I'm typing on the wrong thing. Alrighty, gastroschisis. This is a patho. I'll draw a really cool G here. The intestines are protruding outside the abdominal wall, but originating beside to the right. We have this G here, and it's to the right, beside the navel. Usually just a bowel abdominal wall problem. However, there is no sac covering the bowel. High risk for infection and necrosis. These babies, we want to make sure that we're getting straight to surgery, and the sac is there not to cover the bowel. The sac is not there to cover the bowel. Interventions, we want to keep moist with normal saline to prevent necrosis. These babies will be a definite C-section, okay, if it's caught beforehand. We're also going to make sure we're keep covering with a sterile gauze or a celastic bowel bag, okay? So basically with these, this is really cool because you have, with the gastroschisis, there's a huge gap here. I'm really big on photos. Understand that is meaning that there's no sac covering, okay? So here we have to the right, and there is no sac covering. It is wide open, okay? No sac. Alrighty. NICU feedings, we can have them bottle feed. Breastfeeding isn't completely out of the question. With gavage, this is kind of cool. This is something that occurs if we have a baby, I'm sorry, that has a maybe a cleft lip or a cleft palate. This is when they're sticking a tube down and they're kind of pushing fluids down with a syringe. Maybe even TPN as well. Developmental care, this is care that supports an infant's extrauterine growth and maturation through careful control to the environment. This is, we want to make sure that we're ensuring that these babies are having developmental care. So a lot of times this can be through lighting, sound, positioning, handling, and kangaroo care. This can be accomplished. Okay, next is in regards to kangaroo care. Infants that are eligible for this would be clinically stable infants, if they're intubated, or infants needing a respiratory support. Infants with a UAC, UVC, maybe a PICC line or a peripheral IV. Excluded infants are unstable infants, infants with PALs, peripheral arterial lines, infants with chest tubes, infants with a HFOV or on vasopressor medication. And I would say that I'm not really sure, but I would say that those infants are having some blood pressure problems if they're on that vasopressor medication as well. All right, that's pretty much it. I'm gonna stop sharing. If you guys have any questions, please reach out. It's been a really busy week for me, having an exam myself on Monday already once again. So if you'd like to reach out, just remember my email is going to be blake.montes@tamucc.edu, or any of those PowerPoints as well. You can always see me up on Facebook as well. Thank you and have a blessed week.